is Sam OYER. I'm a facial plastic surgeon coming to you virtually today from the University of Virginia in the United States. I'd like to extend a big thank you to the meeting organizers for allowing me to speak on this topic that's very near and dear to my heart, which is facial reanimation for the non-flaccid facial paralysis patient. I have no financial disclosures. The goals for this short talk will be to first discuss the pathophysiology of non-flaccid facial paralysis and what makes it unique, as well as to demonstrate some treatment options and discuss treatment outcomes for this type of paralysis. When we think of facial paralysis, the image that comes to mind is often this one, which is flaccid paralysis. This is demonstrated by the widened eye, limited eye closure, drooped oral commissures, and all the associated functional and cosmetic deficits that we're familiar with. This happens to be a case of Ramsay-Hunt syndrome, and as is often the case, recovery is incomplete in many cases. This looks like non-flaccid facial paralysis. What you can see here is hypertonic muscles, a narrowed eye opening, tightened nasolabial fold, tightened platysma, as well as synkinesis and synkinetic motion. Unfortunately, a lot of these patients are told, you've gotten some recovery, be happy with what you have, and go on and live your normal life. However, many studies have shown that the quality of life impact, the psychosocial penalty that these patients pay on a daily basis is actually quite high. So many of them end up seeking out care for this non-flaccid facial paralysis, and that's what we're here to discuss today. So let's think of why this would be the case. I want to show you a few examples of smiles. And when you see the photo, just think to yourself, what comes to mind in terms of what emotion do you feel? What words come to mind to describe what you're feeling? So here's the first one. What do you think when you see this face? And then how about this smile? So several researchers have actually looked at this and measured the layperson observer ratings of smiling faces, both with and without facial paralysis. So on the left, you see the non-paralyzed face, and this is expressing joy. People see happiness, people see positive emotions in general, and they respond in kind. The central face shows flaccid facial paralysis. With this, people see a more negative emotion, typically, could be one of sadness, could be one of anger, but often there's also a component of empathy in the observer, recognizing that there's some kind of medical problem going on and something that's not quite right, but there's a little empathy often there. The face on the right, however, shows non-flaccid facial paralysis. With this, we see a strong negative emotion, things like contempt and disgust, and even unintentionally, we often tend to respond with a little less joy ourselves. We tend to respond with more of a negative emotion. And this really creates a feedback loop for these patients. So they get this negative emotion from us, and it builds into their psychology. So why is this happening? Let's take this face, for example, with a left-sided non-flaccid facial paralysis. When we see this person smile, our brain is getting mixed messages. If we were to split this face right in half into the left and the right, and then take a mirror image of each side, on the left side of the screen, you see the unaffected side mirrored on itself, and there's that expression of joy. You see the smile, you know how to respond. You respond with the smile yourself, and that's a positive emotional connection. The image on the right of the screen shows the non-flaccid side. We see that mirrored, and this face actually looks like it's somewhat in pain. It's an expression of anguish. So when we see someone express this to us, we don't know how to respond to that and often portray a negative emotion back to the patient. So really the psychosocial impact of having this face in the middle, where one side's projecting joy and the other contempt or disgust, often sets up this negative feedback loop for patients that really can affect them and really drives them to our clinics looking for care. It's also important to think about the psychology of the patient who has facial paralysis. So here are two examples. The young woman on the left has, as you can see, a more mild version of synkinesis and non-flaccid paralysis. Pretty good movement, good symmetry at rest, good eye closure, a small amount of spontaneous twitching. Her smile coming up is fairly symmetric. Her dental display is really quite good. There is some ocular synkinesis when she smiles and when she puckers, But overall, a fairly mild case of non-flaccid paralysis compared to the woman on the right of the screen with a much more severe case. So in her case, you see really almost no oral commissure excursion on the right side. It's being actively pulled down by the platysma and the depressor. A lot of synkinesis with smile, a lot of chin dimpling, eye closing. So if both of these patients walk into your office, are you able to predict what their quality of life is related to their facial paralysis? Potentially not. We just published a study looking at the psychosocial symptoms of patients, and those with anxiety or depression actually tend to rate their quality of life related to the facial paralysis as worse than we would predict just based on our measurement of their facial paralysis. So the woman on the left with the more mild version, she may actually be more affected by her paralysis than the woman on the right. So this is something we all have to keep a keen eye and keen awareness for, as the psychosocial function of these patients really impacts how they see themselves, and that can impact their function in society. So what gets us to this point? How does synkinesis, how does non-flaccid paralysis develop? Well, there's two criteria that must be in place. There has to be an intact, anatomically intact facial nerve. There also has to be severe enough injury that there's disruption of some of the perineurium and endoneurium tubules of that nerve, so you get incorrect recovery. So with a significant enough injury after Wallerian degeneration, there's really no guiding tubules to help these neurons find their way back. And there can be some axonal sprouting, which leads to increased innervation in some muscles, as well as axon misdirection. So axons that were targeted for one muscle may end up going to an alternate muscle, creating some synkinesis. There's even been changes at the facial nucleus demonstrated in some of these patients. So it's really a complex recovery that's just a fundamentally different facial nerve and muscular complex than it was before the injury. What does this look like then for the patient who's trying to smile, who's trying to express that joyous emotion? On the left, in a non-paralyzed face, the beneficial muscles of the zygomaticus, the levator, and the depressor labii oris, these all contract when we smile. This gives that full dental display smile. And along with that, we have relaxation of the orbicularis muscle, the buccinator, and some of the other muscles that are quiet during a normal smile. On the right-hand side, in a synkinetic non-flaccid paralysis smile, we get co-activation of all these antagonistic muscles. They're not able to relax. So the orbicularis stays tight, the buccinator stays tight, depressor anguli oris and mentalis are actually activated when they should be quiet, as well as the platysma. So we get this classic synkinetic or locked in smile. You see really no movement of the oral commissure. You see no dental display. Those lips are stuck together, as well as standing of the platysma and deepened nasolabial fold. So this, from a muscular standpoint, is commonly what's going on under the surface. So our treatment goals for these patients are really quite different than for flaccid facial paralysis. Here we have to decrease the resting hyperfunction that's present. Also, we have to reduce the unwanted contraction, that co-activation of the depressors that we see along with the desired elevation of the lip elevators. We want to increase lip elevation, but we have to do that at the same time as decreasing unwanted contraction, and the whole time paying careful attention to facial symmetry and improving facial function. So what tools do we have for this group of patients? Really, neuromuscular retraining is a tool that carries through all of these treatments. And this is key and critical. It requires the care of a very specialized trained facial physical therapist. And they will work with patients to really work and retrain that connection between the brain, the nerve, and the muscle. Because again, it's fundamentally miswired and it did not heal correctly from the injury. So they really have to work to learn how to modulate that. Along with that, we'll often add chemodenervation or some surgical options such as selective neurectomy, myectomy, or in some cases, even free tissue transfer. So we'll go through those a little bit more detail. Chemodenervation is really a mainstay for a lot of these patients. And here we're using neurotoxin to weaken and relax specifically those muscles that are spastic, that are synkinetic or antagonistic to our desired motion. So again, this is the same woman. We saw her face earlier, and you see that left-sided non-flaccid paralysis, giving us that mixed message. This shows an example of where neurotoxin was applied into the corrugator, orbicularis oculi, mentalis, platysma, and then the depressor anguli oris. And just with that, with a little relaxation, you can see as the neurotoxin is active, you get a more relaxed facial expression. You don't get so much this feeling of contempt or strain in the face. The face just looks more open, more approachable, and even a more elevated oral commissure in some cases. Another example going a little more detail, looking at this young woman, and in the middle we show the map of actual Botox unit equivalents that were given in the muscles. So showing this in repose, on the left is before and on the right is with active neurotoxin. You see again a little more relaxed facial expression overall. Potentially one missed opportunity in this case was injection into the buccinator muscle inside the cheek. That can help relax some of that lateral commissure pull and deepening of the nasolabial fold that you see even in her treated phase. When she elevates her brow, this is one area where we treat a lot of the contralateral side to help even out and produce more brow symmetry. And you see again more relaxation in the lower face, a little less synkinesis. Eye closure, it's key to maintain eye closure so we don't give people lag ophthalmos or dry eye, but you also can reduce some of the synkinesis that's associated with it. With a smile, by treating the depressor anguli oris, you get a little more elevation of the commissure from the zygomaticus muscles, so it can actually help improve smile symmetry as well as relax some of the tension that you see around the eyebrow and periorbital region in the pre-treated side. Again, a little more dental display can be possible as well, and this is not always as reliable as we'd like it to be, but it is something that can improve with treatment, along with reducing some of that mentalis dimpling that you see here and in the pucker stage. So studies have really shown that treating people with neurotoxin who have synkinesis and non-flaccid paralysis does improve their quality of life as they rate it. It also improves their facial symmetry as we would objectively rate this. So it is something that can help improve quality of life significantly. We have also looked at our group of patients with anxiety and depression and shown that their symptoms of anxiety and depression actually get a little bit better when they're in treatment, even when the neurotoxin is inactive. So even when they're coming back for their next round of treatment, they're not rating their anxiety and depression quite as high. So if it affects their ability to interact in the social environment, it may help reduce that somewhat. So overall, for chemodenervation, there's a lot of benefits here. It's minimally invasive, really no downtime for patients, so it's something attractive from that standpoint. And it's pretty well tolerated. It's non-destructive, so it's not something that you are really creating a permanent change. It's also fairly repeatable. You know, if you take careful measurements and record your injection sites, you can get pretty similar results. You can also adjust those results in a pretty fine way to help make small changes. It really is fairly predictable in the periocular region, the mentalis muscle, the platysma, and it helps with some of the contralateral asymmetry, both in the frontalis and the depressor labii inferioris. The downsides, though, is it's temporary. So patients have to keep coming back for regular visits, which can be a strain on them. It also creates these cyclical symptoms where sometimes they feel great, their face feels relaxed, they're not as tight. And then as it wears off, the tightness comes back. So they have to go through this ebbing and flowing of symptoms as they're waiting for their next treatment. It's not always reproducible, even following a very strict map and really recording your injection site. Sometimes you get a little different response with each visit. And there really can be some limited success in increasing dental display. So injections around the commissure and around the lips can be a little tricky and don't always give reliable results. And some of those patients then that aren't getting quite the reliable results they want or not enough results with neurotoxin, that's where the surgical procedures such as selective neurectomy have really been a game changer for us in this patient population. This procedure was really popularized by Dr. Babak-Azizadeh, among others, and it involves a careful mapping of all the distal branches of the facial nerve throughout the midface, lower face, and neck. And intraoperatively, each of these nerves is stimulated. The motion that nerve creates and the muscle that moves is really documented and observed. And the muscles that are creating antagonistic, unwanted movements, those nerves are selectively cut and a small section is removed, the nerves that produce good movement that we want to see, such as zygomatic elevation, depressor labii inferioris, depression, those are preserved. So just as an example, here's an intraoperative video of a selective nerectomy on the right face. This patient happened to have bilateral paralysis, so both were planned. You can see stimulation of branches that create good lip elevation through the zygomaticus muscles, commissure elevation. These would be preserved. When we see good smile movement like this, those branches are marked for preserving. This branch really produces a lot of lateral mouth movement and some orbicularis and buccenator function, so that one would be sacrificed. This branch produces orbicularis pucker, maybe a little risorius and buccenator lateralization as well, so that would probably be sacrificed as well. Additional branches that produce isolated pucker. This is a decision point in the surgery in terms of how much we want to weaken the orbicularis and risk some of the oral dysphagia following surgery. This branch that produces lip elevation with mentalis is easily selected to sacrifice, whereas this one that produces DLI motion would be preserved. So we're preserving all those branches that create lip elevation or depression and getting rid of the ones that are fighting against that. But there's a lot of subjectivity and there's a lot of intraoperative decision-making and judgment that goes into play for these surgeries. One example of a patient just 1 week post-op, the nice thing about this is you can see results immediately. Essentially, once you cut the nerve, the muscle stops functioning. So above is the pre-op and below here is 1 week post-op. And you can see, especially on the right column with that full dentate smile, much more dental display. And I would struggle to get this with neurotoxin alone. You know, at rest, there's a little more symmetry. And so it's not perfect, but there are ways to get much more relaxed and much better looking smiles for a lot of patients. The results are also pretty durable. So the top here is pre-op, and then the bottom shows 1 year results with no other treatments. So again, a little better dental display in the center column. You see far more teeth. You know, again, the commissure is not perfectly symmetric, and the periorbital region was also not addressed actually with this surgery. So it doesn't address every part of the face, but there are ways with selective nerectomy that you can get some better results than you might be able to with neurotoxin. So overall, the benefits of selective nerectomy, this is a fairly well-tolerated outpatient surgery. You can see results immediately, and it's really good at relieving some of the symptoms of tightness. So those patients that feel like their face is chronically tight, their neck is chronically tight and even painful, they really get a good benefit from this. And they get rid of that ebb and flow of some of the issues with the cyclical symptoms in neurotoxin treatment. The results are also durable, and authors have published, 5-6 year results with good durability. And it's a great option for some people to improve that dental display. The downsides, though, is it's a surgery, it's invasive, and it's destructive. You're taking a section out of the nerve, and you can't really put that back if it happens to be the wrong nerve. So there's a theoretical risk of over-weakening. It's very uncommonly, if at all, seen because these patients are so hypertonic that you often end up with the opposite problem where you haven't taken enough and potentially even go back in to take a few more branches. There is a lot of subjectivity to this surgery where you're really trying to observe the muscles move and determine which ones you like and which ones you don't. So there's a little bit of intraoperative judgment that's needed. Some limited benefit in the periorbital region, and some authors have shown that this will recur and we'll still need some neurotoxin in this region. So it really works a little better for the mid, lower, and neck portions of the face. And the results can be a little unpredictable. Some patient has a great result. The next patient that you treat pretty similarly with a similar branching pattern may not have as good of a result. So that is one downside of this procedure, that it can still be a little bit unpredictable for folks. Selective myectomy is an additional procedure that can be done by itself or added to any of the treatments we've discussed. So this involves taking out the muscle, or at least a section of the muscle that's creating some antagonistic movement, something that's counterproductive for the face. So that, again, this often will augment a selective neurectomy either at the time or sequentially. Some of the main targets would be the ipsilateral platysma muscle. So this, taking a strip of muscle out of the neck, can really help cut down that downward pull, which can actually affect the oral commissure, as well as creating a lot of this muscular tightness and neck tightness for patients. The DAO, or depressor anguli-oris muscle, can be removed to help elevate the commissure on the ipsilateral side. And this is commonly done intraorally and can be done even in the office. Also, the orbicularis oculi could be addressed for that hypertonic orbital squeeze that people will see. On the contralateral side, occasionally the depressor labii inferioris could be partially resected, and this helps elevate the contralateral lip and improve lower lip symmetry overall. So these procedures are attractive as a outpatient or even potentially office-based procedure that have some immediate results and can really relieve some of those symptoms of tightness. They have durable results as well. Once you cut the muscle, it's rare that it reforms, and they can really improve symmetry, sometimes even working on the contralateral side. The downsides, though, is again, it's destructive. Once you cut the muscle, it's cut. Recurrence can occur if you get a fibrous union between the cut edges. So sometimes we'll advocate taking a strip of the muscle out in the center to limit that. However, be careful with that as well, especially in thin skin patients. You can sometimes get contour irregularities where you see a slight depression in the neck or the DAO region where the muscle was cut. And there's limited muscular targets with this. So this works around the eye and the lower lip and neck, but more limited targets in the midface, for example. Both the selective neurectomy and myectomy have also been shown to really improve patient-reported outcomes with synkinesis, as well as observer-graded outcomes. So they can improve quality of life, and several authors have demonstrated that. And finally, the last tool that we will talk about is free muscle transfer. So this is the opposite end of the spectrum. Instead of downgrading the hypertonic muscle or the synkinetic muscle, we're upgrading the muscle function in the areas we want to see to create more smile. So this is just one example of a non-flaccid facial paralysis patient. You can see that left commissure just really not elevating completely because of the coactivation of the DAO. So in this case, a gracilis free muscle transfer was used to help overpower that and help lift the lip to create a better smile. And this shows the same patient 1 year post-op, demonstrating an improvement in that oral commissure position. Now, one caveat with this and the whole concept of upgrading the signal to a synkinetic face, and you might be tempted to say, why use a gracilis muscle? Use a nerve transfer, something like masseteric nerve or even hypoglossal nerve transfer, and let's increase power to the zygomaticus muscles and the smile muscles. Well, authors have also shown that the results for nerve transfer in synkinetic faces is really much more limited and much poorer overall than for flaccid paralysis. Those muscles are already getting a lot of nerve activity and nerve input. So increasing the input by adding an additional nerve doesn't seem to overpower that as well. So we're still trying to work out some of those details, that maybe if you downgrade some of the antagonists and upgrade the agonists, then maybe that's a good combination. But in general, a standalone masseter nerve transfer tends to have pretty limited improvement in a non-flaccid facial paralysis patient. So free muscle transfer really is the main thing that can overpower that synkinetic motion, and it can produce, some reliable movement, the ability to adjust the vectors and some predictable results with the normal caveats of free tissue transfer, of course. However, the downside is it really doesn't address the underlying cause of the smile asymmetry, which is some of that antagonistic hypertonic muscle. It adds facial bulk, potentially. It's significantly more invasive than any of the other procedures we've discussed, and it really only addresses the smile display. It's not very useful for the other zones of the face. So overall, where do we need to go from here? I think as a specialty, it's helpful. We should have some of these goals in mind. One of them is simply to develop more predictable neurotoxin treatment schemes so we can reduce some of the unreliability of certain injection sites. And authors are already working on that as we speak. Another future goal would be to improve our ability in a selective neurectomy patient to predict who's going to have a good outcome and who may not, and also improve our intraoperative decision-making and add some more objective criteria and objective measurements that we can use to, again, help improve outcomes, as well as limiting side effects of treatment for these patients. Really, the holy grail would be to develop a way to help prevent synkinesis in those patients who have flaccid paralysis and are at high risk, something that we can do to limit synkinesis from developing altogether. Then we don't need any of these treatments. So that would be the holy grail that hopefully someday we'll have that discussion. So thank you again for the opportunity to speak. I just want to leave you with a couple of take-home points. And the first is that we know who gets non-flaccid facial paralysis. It's those with severe nerve injury, but anatomically intact nerves and there are certain risk factors for who may or who may not. But recognize that this is a unique subtype of facial paralysis. And these patients actually pay a pretty large psychosocial penalty, and we as society usually respond to them quite negatively. So patients are very affected from a quality of life standpoint, and they really deserve our thoughtful and compassionate care for this disease. The treatment generally focuses on neuromuscular retraining, as well as chemodenervation to cut down hypercontracture and synkinesis. Those are the mainstays of treatment. However, more recently, selective neurectomy and myectomy have been introduced to help improve these outcomes for the more severe cases or provide more long-term results. Thank you so much. Hope you enjoy the rest of the conference.